welcome everybody to this nice hour for this wonderful webinar. On behalf of the reference group, I will give you a warm welcome. I am the co-chair of the reference group and also the chair of the Dutch Center of Expertise in Children's Palliative Care. It's a very special day today, just that's why we are wearing a hat. Today we are celebrating 10 years of Heads-on for Children's Palliative Care from our colleagues from ICPCM. At this afternoon, Jitka will give you a try to run the program.
Thank you, Maggie. Good afternoon, everybody. Or I can see in a chat for somebody, good evening. I'm greeting you from Czech Republic. And I would like to have the honor to present our first speaker, Dr. Erna Michels from Princess Maxima Centrum in Utrecht. And Erna will be speaking about advanced care planning and what we are talking about. Erna, the floor is yours.
Thank you, Jitka. Welcome, everybody. I see you're from all over the world. I'm going to first start sharing my screen. Hope it works. Screen one. And then put it in back. Do we have a full? Yeah, I think this is it. So
sorry, Erna, we can see your speaker view. We can see your notes as well.
Oh, that's weird. Oh, wait, I'll put that in. Oh, wait, I'm going to stop sharing and I'm going to put on screen share. Screen 2. Is this better?
Yeah.
It's perfect.
Okay. So with a little technical problem, we get there. I'm going to talk for the next 10 minutes about what advanced care planning really is, just as an introduction to the next speakers. And I first have a question for you. And you can answer that question. The question is, have you ever in your work experienced a situation in which the end of life phase did not go as the patient or the parents of a patient would have wished? So did you, yes or no? Just to wake you up. And we will wait for a little while to see if results come in.
We have lots of results coming in. Can you see them, Erna?
No, I cannot see them.
No. Okay, so we have 48 people have entered an answer so far.
Yeah.
And I saw a lot of yeses in the chat also.
Shall I end the poll and show the results then?
Yeah, that's good.
Yeah.
It's just to get an idea.
There we go.
Okay.
Can you see them? Yeah.
This is quite obvious. And this is what the answer I get all the time when I ask this question. A lot of us, especially with those with experience in palliative care, have experienced a situation in which they think, okay, this was not okay. So we can close the question. Thank you for answering it. It's the majority of people. So I want to click the next. Oh, yes. So I'm going to talk a little bit about the history of advanced care planning, because this is exactly what happened in the late 90s. There was a growing awareness that the end-of-life care was not good, was not as healthcare professionals thought families or patients would have wanted it. And to show that, less than half of doctors knew what the resuscitation wishes of their patients were, not even half of them. And 38 or treatment or care was, they realized that treatment or care was not what patients would have wanted. For example, nearly 40% of the deceased spend at least 10 days on the intensive care units. So they realized, like, this is not good. We need to do something about it. So they developed what they called advanced care planning. And what is advanced care planning? Actually, it's a process in which the patient or the family, especially when you work with children, sits with caregivers or significant others, might be brothers, sisters, grandparents in our case, to make decisions about future care. And it comprises a few steps. First, you're going to clarify what the patient or the family knows of the disease and of the prognosis and of the treatment options. Because, of course, if people don't have an idea what the disease and the prognosis is, it's no use getting into a real conversation about it. And you clarify the values and the beliefs and the treatment goals of the family and the patient, of course. It's patient-centric. And then you identify the goals of future medical treatments. What is the goal of the treatment? What did they want to achieve? What does it mean for their lives? What are their preferences for future treatments and for care? What are they prepared to give up for it? Or do they want to continue doing everything, or do they prefer quality of life? So it is not, and that's a common mistake I hear, it's not just a do not resuscitation order. It's not, I think in America, it's called a pulse, the green paper on the fridge, like I don't want to have a intensive care, I don't want to have a ventilation. It's much broader than that. It's not just that. And that's quite some mistake, that gives quite some mistakes. And then, of course, after you talk to the patient, you need to document what the decisions were in his medical file, because otherwise nobody can find it again. Why would we do this advanced care planning? Because there have been a lot of studies about advanced care planning and the effects of it. And what they saw was in the British Medical Journal in 2010 was a nice article. What they saw was that patients who were given the opportunity to do an advanced care planning conversation or an ACP conversation, that their end-of-life wishes were better known and better followed than the patients who did not have such a conversation. And the difference is striking. The ones who had a conversation had their wishes followed in 86% and the rest only in 30%, which makes a huge difference. They were more involved in end-of-life decision because they were asked, like, what do you want? What's important to you? They were more satisfied with care, and there was less post-traumatic stress, depression, and anxiety in the family who was left behind after death. And of course, the family, they didn't ask the patient, the family was more satisfied with the way that their loved one died, so with the quality of dying. There were some studies done in children too, and I have to say that these were all children from 12 years and older. And what did they say? They say they felt better informed. It helped with their communication. Also, start the communication between teens and their parents, because very often there is this system of mutual protection, that the teen doesn't talk with his parents because he don't want to make them unhappy, and the parent try to protect their teen from bad news. So they don't talk with each other, but they all both feel the need to do that. So the teen said that the ACP planning started a conversation between them and their parents, and it helped with their treatment decision. And they talked about what they called emotional relief. I'm glad I can talk about it. These teens were followed. They gave no significant sign of depression or anxiety more than other teens. And their quality of life remained maintained, which is quite important, because I very often get the reaction from my colleagues, which are pediatric oncologists, that we don't want to talk about that because they all want, if we talk about worst case scenario, they'll get depressed. They don't want anything at all anymore. So literature shows that that is absolutely not the case. It's the worry of the oncologist and maybe other pediatricians, but not of the parents and the teens themselves. So it's just not true. So if we know what it is and we know why we want to do it, then the question, of course, is how do we do that? I'm going to talk a little bit about my experience, because I'll give you a website where you can find information in English afterward. The first thing you need to do is seek consent. You have to talk to parents and say, like, you know what, I'm giving you an invitation to talk about what is important for you in your life and in your future care. Do you want to talk about that? Because some people just do not want to talk about it. And that's okay, just as long as they are invited to. There's a lot of them who says, yes, I really think this is important. I do want to talk about it, but not just now. And they need some time. So extend the invitation, like, okay, that's fine. Tell me when you're ready for it. And I sometimes, after a couple of months, ask it again. Do you remember I gave you an invitation? Are you ready for it? Yes or no? The second thing, what we learned from doing it is ask who they want to do this conversation with. Do they want somebody from the treatment team or somebody else? And what we realized is there's a lot of patients who do not want to do this conversation with their own doctor because they feel burdened, because their doctor, I mean, working in pediatric oncologist, as a pediatric oncologist, and we have a lot of patients who say, I don't really feel comfortable talking to my doctor because my doctor is trying everything to cure my child. And I feel a little burdened to tell him that I don't want to do all these phase 1 studies anymore because they feel like it's jeopardizing the survival of their child. So you need to ask them, do you want, and some of them want to talk to their own doctor. I had a parent who said, you know what, I know what your idea is. I'd like to talk to somebody else. And that's fine. So ask them who they want to talk to, somebody in the team or somebody outside of the treatment team. And then if they want to do the conversation, prepare the family, say what you are going to talk about so they can think about it. And they need some time to think about it because you're going to ask a lot of difficult questions. Usually that's more than one conversation, because certainly when your child is surviving a very long time, it might be that things change and their ideas change. So leave it open that they always can change their minds about it. Of course, it's patient-centered. As a healthcare professional, you listen to patients and their family. And what helps very lot is use a trained facilitator. Train your doctors, your nurses, everybody who's doing these conversations, train them in doing these conversations. And then very important, what we heard a lot of time is, I wish we could have done this talk earlier. Start early in the disease. Do not start to talk about this when the child is getting rushed into the emergency care unit and ask them, so what do you think we should do now? Because in a crisis situation, parents don't have a space in their head to think about really what do we actually want to do. They want to save their child. So start early when there's still time to think about it. So in practice, there's a lot of ways to do this conversation, but the questions I use are these. First of all, of course, you have to know what the child, or if the child is too young, like two years old, what the parents know about the disease and the prognosis. In my own patients, I know that, but if I do a talk with a conversation with a patient of somebody else, I need to clarify that. And then the questions boil down to what is important to you? What is important in your life, and what is important to you as a family and in your future goals of care? What do you hope for, and what are you afraid of? What do you want to happen, and what do you really not want that happens when the disease progresses? What does a good day look like for your child or for you as if it's a teenager? It differs very much. There are children who say, I can be in bed all day. As long as I have my iPad and I can game with my friends, it's okay. And other children will say, I want to play football all day. That makes a difference in what you're doing with these children. Then the other one, which is very important, which learns a lot about later treatment options, is what is your definition of a good parent? If a parent says, my definition of a good parent is a parent who has tried every single treatment there is to save their child, that's a very other trajectory than when the parent says, I'm a good parent if I can keep my child comfortable, even if that means not living as long as it could be by trying everything. And that is very important, because that is important to know as a healthcare professional, because in the first case, you would offer all phase 1 studies and experimental therapies, and in the second case, you would not. So it's very important. Parents make decisions on this definition. They want to be a good parent, even if their child is dying, and they need to continue for 30, 40 years with, I've been a good parent. So that informs their decisions. And then where do you find support? What helps you in going through this disease and in going in if the worst case scenario would ever happen? These are the questions I use, but of course there's other ways to do that. If you look at this website, there are documents for professionals on how do you prepare for an advanced care planning conversation. How do you prepare? What do you ask? So go and have a look at it. They're in English. You have Dutch, but there's also English on it. So I can very much advise this website, and I hope it helps. And then I'm going to use the words of Anne Richardson, which I think are very important. We cannot change the outcome in cancer sometimes, but we can affect the journey. So that was it. I'm going to stop sharing.
Thank you very much, Erna. I will ask Maggie, you got to press. We have any questions?
I have 3 questions. There were no any questions, but I have questions there's sent us earlier to us. The first is, Anna, who needs to complete this ACP plan you talked about?
Well, depends on you mean who must do the conversation and then fill in the form. Depends on what parents want. When I invite parents, what I said, you ask parents who you want to talk to. If they say, I want to talk to my treating physician, then he's the one doing it. If they don't want to talk to the treating physician, we have our pediatric palliative care team, and all the nurses and the doctors in the pediatric palliative care team are trained facilitators. So we can ask them, one of them. I think what is very important is that the initiative should come from a healthcare professional, because parents fear that talk. Because you're going to talk about, very often in pediatric oncology and in other chronic diseases, you're going to talk about the worst case scenario. Parents don't want, they need to cross a border to do that conversation. And so they're not very inclined to ask for the conversation. So I believe that one of the healthcare professionals should be initiating it. And then ask the parents, who do you want to talk to? And then that person needs to take care of the details of putting it in the file and making sure the conversation takes place.
Oh, clear. Thank you, Anna. 2 other questions from the audience. The first one, how old should we include the pediatric patients in discussing ACP?
That's a good one. That's, of course, a difficult one. You need to be sure that the child can understand what you're talking about. We actually looked last year, we did a research on, is there anybody having a conversation for children smaller, younger than 10 years of age? And there was no one who had that conversation ready. But of course, there is a technique of, if you do the conversation with the parents, because the child is too young, one of the questions might be, how do you think your child would answer this question? So what would your child think about this? If I asked, for example, if you ask the parents, what's important to you? Then they'll tell you what they think is important. And then you can ask, and what would your child think about that if you asked him? So you can involve the perspective of the child by asking the parents. But of course, I mean, the perspective of the child by asking the child itself would be better if he's old enough to understand questions.
Yeah. How many people are in this conversation, in ACP talk? Is it the doctor?
Depending on what the parents want. First, you ask them who they want to have there. If it's a teen, he's usually in there. You ask the parents, do you want to have this conversation with your child or separate? And we also, sometimes we have parents who have a different view. And then we say, like, you want to have this talk together or you want to have this talk separately? So it might be one healthcare professional at least, one parent, the one you're talking to, with or without, 1 or 2 parents, with or without the child. So, and then sometimes they want to have well, a significant other, which might be a grandmother or a sister of the mother. So in between, let's say 3 to 5 people, but depending on what the parent wants.
Okay. And the last question, and it's a very interesting one. How do we manage if the parents want to change their decision regarding end-of-life care?
If they want to change their decision in the, well, then it changes. I mean, it's open. I always say, like, you know what? We're going to write this down, but it's not in stone. If you ever change your mind, tell us, we'll do the talk again. They can always change their ideas. It's not like, oh no, you said 2 years ago that we're not going to resuscitate, so we're not, or that this is important to you. Of course, it's open to change. And in chronic disease, there is this rule that says, when do you need to redo the conversation? It's the 3 Ds. Every decade, in a time of decline, and in a time that serious decisions need to be made. So that's one guideline. But of course, if patients say, hey, you know what, doctor, we've changed our mind, well, do the talk again, or ask what changed their mind. My experience is that they don't very often change their minds. But that's my experience.
Okay, thank you very much. There are coming more questions in. We will answer them, but I think we have to go to the next speaker.
Yeah,
Okay.
Thank you, Anna, and thank you, Maggie. I'm very happy you find the Q&A box, and please put your questions there. We will have a space for answer them. Let's see, and thank you, Anna, for reminding me that's a process. We need to invite the patients and the families to do the advanced care planning. And I would like to now ask Sidonie Schroeder for her story about and sharing personal experience about the importance of advanced care planning, because Sidonie is a mother of a deceased daughter, Milo. Sidonie, the floor is yours.
Okay, thank you. Thank you. Thanks for your time. So I'm here to talk about the parent perspective on advanced care planning. Let me also share some slides. 1 second. Okay, one moment. Should be good now. Yes?
It's perfect. Yeah, we can all see it.
Okay. Well, so I'm the mother of Milou, which is this beautiful lady in the middle, and of course a lovely husband, but that's not the talk is about. Milou is so I live in the Netherlands with my family, and Milou is our oldest child. This picture was made about 6 months before she passed away. She was almost 10 at the time, and you know, I could sit here and talk to you, I think, the whole session and the whole day about how great she was, because she was wonderful and she had a great smile and she was perfect. There was in that sense, as a mother, nothing wrong with her. However, there is another side, otherwise I wouldn't be here. And also because of all your interests, and because I think it's very important to improve this advanced care planning. So that's why I'm sharing the other side of the story. So Milou, as you can see, she was only 10 years old and she passed away. She's the oldest child of 3. We have 2 other children, and my son is now 13 and my daughter is 11. They were 4 and 6 at the time she passed away. So we were actually we were a happy, complete family. And completeness is so important, because that's what we've been missing for the last 6 years. And I think that so if we talk about everything, we were really happy with her, but there was a lot of care. And when she was born, nothing was wrong with her. It seemed nothing was wrong, but she got sick after 2 weeks from a little flu and ended up in the hospital. And that's a snowball that started rolling, that never stopped. We only got an 80% sort of diagnosis, I think 9 months after she passed away. And I think in all the 10 years she lived, on a daily basis, often on an hourly basis, the only question what we were worried about is what is wrong with her. Because so pretty soon after, I think after after a couple of months actually already, there was something wrong, but we didn't know what. And at the end, I think Milou, she functioned at around 3 months max. So that was kind of her age. Maybe 6 months sometimes. She could sit a little bit, but you had to kind of hold her. She could not speak, so she would only make noise. So smile, laugh, cry, scream. So she was very, very limited and very, very disabled in every aspect. But that was everything that we could live with that. The only thing that was very tough, and that became tougher and tougher, is the pain she had to live with. And so we visited, this is just a short summary, but there was a lot of doctors, a lot of hospitals. We went everywhere, but nobody really knew. And we didn't really care about her diagnosis at a certain point, because it was all about how can we get her comfortable in the moment? How can we just get her to relax, to be at ease? And that was a constant struggle that was very much recognized, but was not easy to solve. And she didn't have a formal progressive disease diagnosis, but everybody knew at a certain time that was the case, because everybody around us saw that she was going backwards instead of standing still or going forward. So that's basically what happened over the years. And so most of her life was basically suffering. She was just in pain almost all the time. And yeah, at a certain moment, that's where I think the impact of ACP comes around the corner, especially in a complex situation like with our daughter. For us, it's kind of the word that it led. If there's not, at the time, there was this whole ACP concept was not really there, not for us in our specific circumstances. And although we had very good doctors, we had good people, good intentions, and everybody seeing the pain, everybody feeling the pain, everybody wanting to help, but at the end of the day, we didn't get anywhere. And the only thing that we had is that our daughter, every time we'd go to the hospital, she'd get even worse. And she just couldn't handle another location. She was home 24/7. She sometimes couldn't even go outside. It hurt to kind of change her diaper. And so everything was too much. So we did, as a parents, did what we felt was right, is to keep her home where she felt at least a bit more comfortable. But that did mean that we were, the hospital is only 20 minutes away from our house, but it was kind of far away because the doctors, they didn't come to our house, and Milou needed the doctors at the house. And so for us, although we're not blaming anybody and everybody did their best, it was a big administrative machine for us, and where a child with so many bodily problems as well, that there's so many specializations and so many people that had to be involved. It took too long, it was too complicated, and it didn't help her. So, and I think in also going towards the end where she really got worse and worse, it was also a bit of a dilemma, because we also kind of felt that it was difficult for them. They kind of also felt, they didn't know how to help us, but we didn't talk about it, not really. And as a parent, that's why it was good what Erna mentioned, that the initiative should come from the professional and not from the parents. We were actually constantly forced to take initiative on these kind of discussions in all hasty 10 minutes meetings, but that's not right. It's mentally not good for parents. At least wasn't good for me, but I think it's really good that it comes from the professional and not from the parents, because I think then basically you already missed the ball a little on that one, is my personal view. But so at the end for us, it kind of felt, which is the element that was in the previous slides about, the results of from research that there's that there's really anxiety, depression, and post-traumatic stress. I can really relate to that because, of course, her pain was the most important thing. And also, of course, when she's not here anymore, we miss her daily. But on the second place was really that feeling of that systems failure. That, I mean, the Netherlands is a great country with a lot of good care, but it didn't fit for us in what we needed and what our daughter needed mostly. So it was for us, this was difficult. What we ended up doing, because there was no real ACP for this kind of situation, we pulled back because we needed to, and we found our own doctors who were able to come to our house and to help us with what we needed in terms of the care at home, and looking very closely on what was needed at the moment. And I think that was the moment that things really turned around for us. And that's where the last 6 months of Milou's life, basically we could actually work together very closely with these doctors, and we really experienced how ACP sometimes to some doctors maybe or professionals comes naturally, but it was actually perfect. We kind of joke about it now and say it was, we had a dream team. But the good thing was that the first meeting we had with these two new doctors, one which we already knew, and the other that was a specialist in palliative care, they showed us this picture for the first time as parents, and it's in Dutch, I know, but the middle word in red is suffering. And the doctor pulled out this picture, and it was so confronting for us to see it, even though we knew it. Like, it's about all the levels of suffering, like functional, psychologically, socially, existentially, spiritually, bodily. And we really talked about all that from my daughter's perspective. Because of course she couldn't talk herself, but she could indicate clearly how she was feeling. So that was really confronting, but it really, really helped us. And in that sense, for us, I'm a strong believer of the fact that it really does help to start these conversations in a much earlier phase and not restrict them to the non-resuscitation policies and those things. We've all had that, but it's nothing compared to like these kind of talks. And even though a parent may not be ready or maybe angry with you about asking the invitation to discuss, at the end it's good that it's there. And I think also, so if you so that advanced care planning, for us, it was 10 days that we had with her when she couldn't eat anymore, that we had 10 days to say goodbye, basically, but in the way we wanted to, because we thought it would be fit for her, and which meant going for a walk every day. But also, and I think that's also advanced care planning for brothers and sisters, which is important, because it was very interesting that our 4 and 6-year-olds at the time were basically already also doing advanced care planning, because they started drawing without us telling them to. They started making a book for the doctor because they wanted to ask their own questions, because they kind of wanted a verification, because they believed our stories, but they thought, this is a big thing. Something's happening to our sister. We want to know. And we arranged a conversation with the doctor, with our kids, so they would get the podium, and they had these booklets with them, and they had questions like, what is it going to look like when she dies? Why did the epilepsy kill her? I don't know, the things that they found important to ask. So for us, I think a result of very good advanced care planning is also that these very valuable moments and things the time you have left to spend them in the right way are really what leads to that. And it's not only the before, but also the years after, that it's so important to address those things, to make sure that, also the attention for the real important things also that you want to do with the child before the child is not there anymore, and after is so important. So that's also why I think aftercare is something, I don't know if that's a real English word, but it's a translation from Dutch. But I think that, so in our time, it was a conversation. I think the doctors had in their protocol that it's a conversation after 6 weeks after the patient dies. And to be honest, I remember the moment that they came to our house to have that conversation, but that's all. I wasn't at all interested in that whole conversation and wasn't there yet. So I think 2 years later, we had the real conversation. So it's really also what Erna said, is talking about what do the parents want and what do they need. And I didn't need that conversation. I remember appreciating them coming and doing it, but it had no value. But afterwards it did. And again, one of the doctors even sends a card to us on her birthday. I'm not saying that has to be part of protocol, but it's just different for every situation. And it's just good to think about your own role in that, but also to ask and also indicate what you can do and what you can't do. But it is good for, I think, professionals to realize that the importance of this whole ACP goes far beyond a couple of moments that you're in the room with these parents. And that's in terms of the slides, what I wanted to share. I trying to stop sharing, but yeah, so again, I can talk for hours about my daughter and also about a lot of the things that were difficult, but I'm more interesting maybe also in questions, if there are any. Happy to ask anything you want to know specifically. There's a lot to say, but there's a short limit on time maybe, so.
Thank you, Sidonie. Thank you for letting us peek into your life with Milu, and not only the struggles, but also the love we can feel from you and hear from you. You had together as a family. And I don't know, Maggie, are there any questions to Sidonie? Or?
Sidonie, there were a lot of hearts for you. At the moment you talked about including siblings. So you get many, many hearts.
That's good. I'll tell them. I'll tell the children. They know I'm presenting about their sister, so I'll give them the hearts. I don't know if my adolescent son is going to like the hearts, but we'll try.
Yeah, and a lot of thank you very much for sharing your story. Yes, very impressive.
I'm happy to answer a question. Don't hesitate.
Yeah, I have one question.
It's difficult, so try on me, even though it's difficult.
I will try on you. I have one question. I will try on you. Do you have, from the perspective of a parent, any idea why we didn't start earlier with ACP talk? What are the barriers? What do you think are the barriers? Do you feel barriers as a parent?
Yes, and yes, I felt barriers at the time, and so I think as a parent, I think it's good that professionals know that parents feel if there's a barrier on the other side. So, and I think that because this is such a heavy topic, nobody wants a child to die, that even the professionals should realize that if they have difficulty with this topic, it's going to come through the filter, and no parent is crazy when it comes to their child at risk. So I think it's the barrier is basically where, and also the fact that I think, but I'm not a doctor, but inherently a doctor, of course, wants to make the patient better and wants to solve the problem that lies in their face. But that's not always possible. And I do think that inherently in the personality type of many professionals, even they may say no, that is the case, that they don't, this is a difficult part also because it's not black and white. We didn't know. My daughter could have turned 30. So wouldn't she, and also maybe culturally, maybe insulting us. I think it's kind of scary to start out of on this topic and kind of be like, it's the wrong timing. But I know from other parents that have experienced a wrong timing where they got angry with the doctor that started. They hated the doctor at the time, which was my favorite doctor, but they really hated her. But then after a year after their daughter passed away, they said this was, at the end, retrospectively, my best doctor, because if the doctor hadn't started that asking the invite, they wouldn't have really known that what was happening. So they were able to enjoy their daughter more, but the doctor never heard that, right? So it's part of your job, and you don't always get that message afterwards.
Yeah.
But I do think those are like barriers.
Yes, thank you. Jitka, did we have a minute or two? Minute?
I think 1 minute, yeah.
Okay, we have the two other questions. One is, how did you feel in the aftercare meeting with the doctors? Would you prefer a different, maybe? Who felt it for you, Sidonie?
Yeah, I think, well, I think the aftercare meeting for me, I was not there. I was not alive. So I remember really, it's like where we sat, but I have no recollection of any of the conversation. But that's really personal, of course. But I do what I said, feel that it was, I appreciated that they had it, but I think that's not it. They should ask what's needed, and is that timing okay? The aftercare conversation we had later on was much better for us in timing, and I think that's good to realize that 6 weeks, there's no good timing, but just suit the timing to the needs of the parents and the other family members. I think that is most important.
Yeah, I have one other question, and that was, there are many questions now. You may have spoken to other parents and families regarding you and their difficult journeys at the end of the life of the child. When you speak about the place and time for discussion, how can you advise a professional to discuss ACP?
I think, first of all, is the fact that generally the people, I think, to be honest, doctors are always in a hurry. And even though maybe you're the exception, but doctors always look hurried and you feel rushed. But that's also what I hear, that doesn't help the conversation if somebody is constantly with a beeper or looking very tired even. We had somebody where the intern literally fell asleep in a very serious conversation because the intern was so tired. So the fact that you're in a good state, you're not rushed, you can close the door, not be disturbed, give more than 10 minutes. I think that's really important. And I think that's for a lot of people, maybe right or wrong, the perception.
Thank you very much, Sidonie. It's very, very nice.
Thank you.
There are more questions in the Q&A, so we will try to answer them all.
Okay. Thank you, Sidonie, for reminding us that sometimes we try to hide our, fears and tiredness, but you just confirm you can see it as a parent, as a patient, or as somebody who's standing in front of us. Thank you. We need to hear it sometimes as well and be reminded. And please put your, before the last speaker, I would remind you, put your Q&As in a Q&A box, and we will try to answer them at the end, or have the speakers to answer them, to write an answer in the box. And now I would like to invite to speak Julia Downing, who's an executive director of ICPCN. That's why we today wearing hat, because that's 10 years anniversary of this advocacy event to bring awareness to children palliative care. And Julia will talk about research and international development of advanced care planning.
Thank you very much, Jitka, and thank you very much, Sidonie, for introducing us to your daughter, Milo, and also your experiences. And I think they will very much link into my presentation. So I'm going to be looking at research and international developments in advanced care planning, and I'm kind of do that together. So we're going to have a quick trip around the world, looking at a few different examples of research and development in advanced care planning around the world. Now, I think one of the important things to start off is that there are many different words that are used, different terminology, and These are all the English versions. Once you start translating them into different languages, there are many different terms that are often used to think about advanced care planning. So I'm going to take you on a quick journey. We're going to start off in Australia, then I think we're going to go to Brazil, and then the UK, then Africa, then back to the UK again, just to get a feel about advanced care planning in different countries. And I think it's really important to start off with the fact that, firstly, children's palliative care is in different stages of development in different parts of the world, and so is advanced care planning. So if we start off in Australia, and this is some work that has been done by our colleagues Jenny Hinson and colleagues at the Royal Children's Hospital in Melbourne, and they have what they call the Thinking Ahead Advanced Care Planning Guide for Children with Life-Limiting Conditions. This is available on the website, and I will share the link. And this looks at issues around policy. It shares a framework for how you can have some of these conversations. It includes a discussion guide and a policy document. So this framework very much thinks about this process in 4 steps. And I think some of these steps we've heard of from Sidonie, but the first one around living with a life-limiting illness, thinking about what is important for the child and the family now, what is it important for them in their daily lives, but also thinking about the future. What is important? What are their hopes and fears? What keeps them awake at night? What might be some of their goals? Thinking about what will happen in terms of current or potential future deterioration. And there are many different issues that can be addressed in this section. But I like these words that they suggest. I really hope maybe its chemotherapy is successful. But if there were ever to come a time when your child was deteriorating despite all of these efforts, have you had any thoughts about how you would want that to be? For example, where would you want to be? And of course, personalizing this for the child and the family, but just for those people who might be worried about some of the words to use, they give some examples. They then have a goals of care document, which you can talk through with the family, with the child or the young person where appropriate. And again, as I think we've heard right through, these are ongoing discussions. It's not just one discussion that takes place at one time, but it's an ongoing discussion. And then step 4, they talk about end-of-life care. So this is a framework which can be useful, and it obviously goes into a lot more detail. We then move on to Brazil. There's been some work published just recently by Tardelli and colleagues in 2023 around advanced care planning in Brazil. And they say that much of the debate around advanced care planning is around legal issues. But most of the education in Brazil on advanced care planning helps in palliative care. So therefore, most advanced care planning discussions are by those trained in palliative care. But then they also go on to say that due to the scarce access of palliative care and these challenges around access, then often advanced care planning discussions are occurring late in the course of the illness. And one of the challenges here is that this is for advanced care planning generally, not specific to children and young people. But if you think about in Brazil, there is even less access to palliative care for children and young people. So therefore, again, hindering some of the discussions around advanced care planning within the context of palliative care for children and young people. So then if we move over from Brazil, I'm just going to share some work done by Karen Carr, and Karen is on this call. So welcome, Karen. And she's recently completed her PhD, which was looking at issues around initiating discussions around advanced care planning. And Sidonie touched on some of this and really important information as to how do we initiate discussions around advanced care planning. This was work done in the UK and the Republic of Ireland. That was 4 parts to her study. And I'm just going to share very briefly a couple of slides around some of the thoughts on this. So the health professionals, they felt that we have a duty to talk about it, and it's important to talk about it. And it's important not just for planning, but so that parents and families can share their fears, can talk and not feel isolated. But at the same time, some say that it's in your instinct to run the other way because you don't want to make anyone else feel more uncomfortable or upset. And there was also this feeling that it's important to remember that whilst you might have to fill in a piece of paper, it's not about that piece of paper. It's about the discussions themselves around advanced care planning. But also there was this talk about, are the parents ready? And again, we've heard about this already in this session. And how do we as health professionals know whether a parent is ready to talk about it or not? And I found that this one was, this quote was interesting. The only way you can establish their readiness is by asking. You can't assume that they're not ready, just like you can't assume that they are ready. And maybe it's by bringing in this information bit by bit and giving the parents opportunity to talk about it that you will find out whether they're ready and whether they want to engage in that discussion or not. So it's really important for us to give that opportunity. But we've already heard from the parents' perspective, from Sidonie, and many of the parents that Karen spoke to talked about the importance of talking about it. This one parent talks about the fact that the end wasn't so scary because you've thought about it. You've made some decisions, or at least started to think about it, and then you can come back to it, can't you, and revisit it. And one of the questions we had earlier was, what happens if parents change their mind? And that's okay. It's another parent said, it's like the more decisions you make along the way, the less things you are deciding on when things are very emotional and very fraught, and when perhaps you're not in the right frame of mind. But also it's important that if you have these discussions, that the health care professionals, that we value and respect opinions. And there was one parent here who was talking about when it wasn't quite as she'd hoped, particularly in relation to giving fluids. So there was, in summary, there was issues around when do we have that conversation? Who has that conversation? How do we have that conversation? And that really important issue of trust. And I'll give you links to all of the papers on Karen's work. But what about a completely different setting? What about in Africa? And this is some work that was done by a colleague, Diana Berzerica, and colleagues, that should say 2023. And she looked at the use of advanced care planning in sub-Saharan Africa. She found in her participants from 9 different African countries that whilst many of them had heard about advanced care planning, not many of them had actually cared for a patient with an advanced care plan. Some didn't even know if their patients had advanced care planning. Most of them said they would respect a patient's advanced care plan. Not many had written their own or had even thought about it for themselves. But the results of their study, they felt that the results make a compelling argument around the fact that education can really help in the implementation of advanced care planning within sub-Saharan Africa. And that's really important to think about advanced care planning within different settings. Some more work done by Samuel Guma and colleagues in Uganda looked at some of the barriers to advanced care planning, but also some of the facilitators. And I think one of the important things that came out in Uganda, and there's some studies done in other sub-Saharan African countries was issues around social and cultural factors and religious factors. The fact that often discussions around death and dying are seen as taboo, maybe only for religious leaders, but also in some cultures, if you talk about death, then you're seen as bringing death on to that person. So you are seen as being responsible for it. So how do we talk about advanced care planning in cultures where this is the case? And also in many cultures, family members often request the patient is not told about their prognosis. Now, again, trying to actually bring out studies specifically on advanced care planning in children and young people in countries where advanced care planning is not well known is quite difficult. And so many of these studies have been looking generally at advanced care planning. But if we go back to the UK, I just wanted to share with you some work that's been done through some initial research work and then developing onwards a standard framework for advanced care planning for children. So one of the things that we've heard about is actually the importance of education and training and support for individuals involved in advanced care planning. And we've been asked, well, who should do those conversations? Who should have that conversation? Who should initiate it? When and how? So education around advanced care planning is really important. And so in the UK, the Children's Palliative Care Education and Training in United Kingdom and Ireland Collaborative have helped and worked with the Advanced Care Planning Collaborative to actually look at education and training for advanced care planning. So within this framework, they have 4 levels of education from public health, universal, core and specialist. Building on the type of education that is needed around advanced care planning at the different levels of care provider. So they have identified different learning outcomes specifically around advanced care planning, around communication, around working with others and across different settings, around managing and identifying symptoms, and then sustaining self-care and supporting the well-being of others. And they go into in detail the proficiency statement. This is at the universal level. So the proficiency statement, learning outcomes, some suggested content, how we might evaluate it, and also at the specialist level and at the different levels. Now, this can be downloaded from the ICPCN website. So I won't go into too much detail, but it's another resource that is available. And we have been looking at the wider framework and looking at how that applies in an international context. So just to say, all of these resources, along with links to the sites that Anna was talking about in Australia, can be found on the ICPCN website for you. And just to close, I just want to mention Lucy Watts. Many of you will know, have known Lucy, who sadly died earlier this year, but she spoke a lot about the importance of advanced care planning. She spoke about the importance of getting the right help at the right time from the right people, and knowing that the team around her knew what her needs were. And yes, Lucy had an advanced care plan, and yes, that changed over time. And sadly, it didn't all plan out as she'd hoped. But it was so important for her to have thought these things through, to have discussed them with her family, with her mother, with her sister. She wanted to be empowered and knowledgeable and prepared for what was going on. And she said, we all have the power to give a good experience for patients and their families through life and end of life and beyond into bereavement, by keeping the patient experience at the heart of care, by really understanding what was important for the family, for the parents, for the child and young person themselves, for their siblings, and really opening up these conversations in advance. So a quick dash around the world. I'd like to thank you for for taking part in this. And there is so much that we can learn around advanced care planning. But I'd like to again thank Sidonie for talking to us about Milo and about sharing her experience on the importance of advanced care planning. Thank you.
Thank you, Julia. Maggie, are there any more questions?
Yes.
Either to Julia, Sidonie, or Erna?
Yes, one question, but in matters of time management, I will say let's answer it's a longer question, so let's answer the question afterwards. And I will thank also the speakers, wonderful speakers. Thank you very much, Julia. And I remind, congratulations for the 10th Hands-on Children's Palliative Care Day. It's a great day, a great initiative. And thank you also for Erna Michiels from the Netherlands for her stunning presentation, and also Julia. So thank you.
Thank you all for joining us today. You see lots of in a chat room. You have lots of websites for the resources our speaker talked about. So please click on them. You know, this is recorded, so it will be available also later. And for the certificate, don't forget, if you need certificate and want certificate, please fill up the evaluation form. There is also a link in a chat room. And thank you to all joining us for today. Have a lovely Friday, lovely weekend. And we hope to see you next time in our webinar.